Of you. Good evening, everybody. Good evening. Welcome to the MIQ series for NEET PG and FMGE. All of you, can you just write in the chat box, I am visible, I am audible, and then we'll start. My name is Dr. Sidharth Sethi, your DAMS Pediatrics faculty. Good evening, everybody. And I hope all of you gave these questions in the NEET app. You attempted all of these questions, and now we will be talking about the answers of those questions. So am I audible, visible, cool? Let's start. So the first question and the most important question is that in every exam of yours, you will have a child who will have something related to vasculitis. So here is a 3-year-old boy who comes to you with fever for the last 6 days, and in addition to fever for more than 5 days, he has 4 more criteria: conjunctival inflammation, red cracked lips, a rash, swollen hands and feet, and a big unilateral lymph node more than 1.5 centimeters. There is no other infection. So can anyone in the class tell me the diagnosis? This is classic Kawasaki disease. These are the classic features of Kawasaki disease. So guys, let me show you from our DAMS workbook the diagnostic criteria. Remember, all of you should know that Kawasaki disease is seen in children less than 5 years. Remember, 80% of Kawasaki is seen in children less than 5 years. Okay? And all of you need to know the diagnostic criteria. This is from the new DAMS workbook. Fever for 5 days and 4 of these 5. Changes in the extremities. So there should be changes in the extremities. Acute. Erythema of palms and soles. Edema of hands and feet. And remember, in the 2nd to 3rd week of illness, you can see peeling of the fingers and toes. A polymorphous rash, remember, it is never vesicular. It is a polymorphous rash. Bilateral conjunctivitis without exudates. Remember, it's a non-exudative conjunctivitis. Erythema and cracking of lips. There may be strawberry tongue, may or may not be strawberry tongue. Cervical lymph node more than 1.5 centimeter, unilateral. So all of you agree with me, these are the classic. So this child has all the classic features of Kawasaki disease. Now the problem in Kawasaki is that these children can get coronary artery aneurysms. Almost 15 to 25% according to OPGI textbook can have coronary artery aneurysms. So the drug of choice, and all of you are right, the drug of choice is giving high dose aspirin and IVIG. So most important is IVIG, 2 grams per kg, and we give aspirin according to OPGI textbook 30 to 50 milligram per kg per day till the child is afebrile for 48 hours. So by giving this IVIG, the risk of aneurysms reduces to 4 to 5%. Cool. Let's go further. Let's talk about the second important question, hematuria. So here is a 10-year-old boy, and this 10-year-old boy has got dark colored urine. And now the catch is 2 days after a sore throat. It's a synpharyngitic hematuria. Synpharyngitic hematuria. His BP is slightly on the higher side. Urine shows hematuria. CAS C3, C4 are normal. There is no family history to suggest that this is Alport's. In Alport's, there may be family history of hematuria, family history of kidney failure, hearing loss. So remember, this is not post-streptococcal GN, because post-streptococcal GN usually occurs after 2 weeks of sore throat and 4 weeks of pyoderma. So this is not post-streptococcal. Okay. Now what is your answer? Anyone in the class? Yes, this is IgA nephropathy, because IgA nephropathy is the typical synpharyngitic hematuria. synpharyngitic, number 1. Number 2, it's the most common cause of recurrent gross hematuria. Okay. Okay, so this is not PSGN, Dr. Patel in the chat box. Alport syndrome is also seen in boys, but it has a typical triad, triad of eye problem, anterior lenticonus, deafness in the ear, and kidney failure or hematuria. This is not MPGN. In MPGN, C3 is low. So the answer is IgA nephropathy. Okay, answer is IgA nephropathy. Okay, let's go further. Can we go to the next question, all of you? So remember, post-streptococcal GN occurs after 2 weeks of a sore throat, 4 weeks of a pyoderma. Okay, can we go further? Let's go to question number 3. Here is a 2-year-old girl, and here's a 2-year-old girl who comes to you with poor weight gain, and we are telling you that this 2-year-old girl mid upper arm circumference is 10.5 centimeters. Mid upper arm circumference is 10.5 centimeters. She has bilateral pedal edema. Now, which of the following will confirm the diagnosis of SAM? Anyone in the class? Which of the following will confirm the diagnosis of SAM? Anyone in the class? So all of you should know SAM is important. Severe acute malnutrition is important. So all of you should know the criteria of SAM. All of you should know what is SAM. So SAM is defined as in 2 age groups, 6 to 59 months and less than 6 months. So in 6 to 59 months, as any of the following, remember severe acute malnutrition का criteria है weight for height less than -3 standard deviation or bilateral edema or mid upper arm circumference less than 11.5 centimeters. Less than 11.5 centimeters. Okay. Now in children less than 6 months, we don't take mid arm circumference, so we take criteria number 1 or 2. Okay. So remember, weight for height less than -3 SD. Okay. So coming back to the question, this is wrong. It should not be -2, it should be -3 SD. Okay, mid upper arm circumference is the answer of this question. Weight for age is not a marker for SAM. Bilateral edema is a marker of severe acute malnutrition. So the answer is mid upper arm. Okay, there is no height for age here in the options here. Okay, so remember Dr. DP in the chat box, SAM का criteria है weight for height. मैं चलो जोर से बोलता हूँ, सब लोग लिखो चैट बॉक्स में, SAM is weight for height less than -3 standard deviation or bilateral pedal edema or mid arm circumference less than 11.5 centimeters. Okay, remember this. Let's go further. Now the next 2 questions are very important. Remember, celiac disease is a very important question, very important topic, but somehow you miss it. So I am asking you that if someone has symptoms, here is a 4-year-old girl who's got chronic diarrhea, abdomen distension, is not growing well. Now what is the first test in a case of celiac disease? Anyone in the class? If you are suspecting symptomatic celiac, this patient has symptoms of celiac, according to the Aspagan, all of you need to know that we follow the Aspagan criteria, the European Society of Pediatric Gastroenterology criteria. So nowadays we don't do duodenal biopsy in all celiac. So the first test to do in any suspected celiac is IgA levels and IgA TTG2. IgA levels and IgA TTG2. If these two levels are negative, it is not celiac. So IgA is normal. So remember, in every case of celiac, first we confirm that IgA should be normal, because 5% of celiac may have IgA deficiency. So we have to do both IgA and IgA TTG2. Now if the levels are more than 10 times the higher limit, then we'll do anti-endomysial antibody. We look at the HLA, DQ2, DQ8. याद रखना है, क्वेश्चन आएगा, मैं बता रहा हूँ. HLA, DQ2, DQ8 is associated with celiac. If it is like this, anti-endomysial antibody is positive, HLA is there, straight away start him on gluten-free diet. Gluten-free diet. We only do duodenal biopsies if the levels are less than 10 times the normal. So remember, we only do duodenal biopsies if levels are less than 10 times the normal. Okay, remember this. So all of you are right. Yes, we will do IgA levels with IgA TTG2. Everyone in the chat box is right. But now let me add a twist to this question, everyone. And the twist is, what about his brother? This girl we have diagnosed as celiac, but what do we do in a asymptomatic brother? Can anyone in the class tell me now? There is a twist now. What should you do in a asymptomatic sibling according to the European Society of Pediatric Gastroenterology guidelines? So remember, if you have an asymptomatic patient, let me show you the protocol according to the European Society. So according to the European Society of Pediatric Gastroenterology, which we follow everyone, even in India, if you have an asymptomatic at-risk patient, HLA is the first test. You get HLA DQ2, HLA DQ8. So remember, in asymptomatic siblings, at-risk patients, you do HLA first. HLA first in asymptomatic. If HLA is positive, then you look at the TTG and IgA. And if TTG is more than 3 times the higher limit, we do a duodenal biopsy. So this is a slightly different algorithm, but you need to know, guys. Okay. This is according to the European Gastroenterology guidelines. Okay. Do the HLA first. This is the algorithm also given in the Nelson's textbook. And then we look at the TTG. If TTG is more than 3 times, you do a duodenal biopsy. If it is less than 3 times, we look at the anti-endomysial antibody. Okay. Can you just write cool in the chat box? Can you just write cool in the chat box? So HLA has to be done in asymptomatic sibling. Okay. So if I show you this question, I will begin the screening with HLA. Okay. Very important. Cool. Let's take you to the next question. And मैं लिख के दे देता हूँ, नीट पीजी में, FMG में, टॉर्च इन्फेक्शंस पे क्वेश्चन आएगा. So please look at our back to basics lectures. In my back to basics lectures, there are 2 sections of torch and other intrauterine infections. Very important. So let me first start with a child who has petechiae, hepatosplenomegaly, microcephaly. He has periventricular calcifications and has deafness. He failed a hearing test. So remember, number 1, this is of course CMV. Remember, in CMV, number 1, we see periventricular calcifications. In CMV, you can also have cortical atrophy of the brain. Cortical atrophy of the brain. Remember, CMV is the most common torch infection. Most common torch infection is CMV. And remember this deafness point. I'll tell you a straight away sentence from Nelson's textbook. CMV is the most common non-syndromic sensory neural hearing loss. Okay, it is the most common non-syndromic sensory neural hearing loss in children. Okay, non-syndromic. Now remember, when we talk about rubella is a triad of deafness, PDA, cataract. They can also have peripheral pulmonary stenosis. Rubella can also have peripheral pulmonary stenosis. Now remember, in toxoplasmosis, the calcifications are in the basal ganglia. In toxo, calcifications are in the basal ganglia, and there is hydrocephalus in toxo. Remember, calcifications block the aqueduct in toxoplasmosis. In herpes, remember, it usually presents with bleeding at day 5 to day 10 of life, usually bleeding and vesicles. Bleeding and vesicles classically over the medial canthus. Let's go to the 7th question, and this is a very important conceptual question. The question is about cystic fibrosis. Here is a 6-month-old child who has foul smelling stools. Remember, cystic fibrosis is the most common. It is the most common cause of steatorrhea in children all over the world. Cystic fibrosis is the most common exocrine pancreatic insufficiency in children. Exocrine. Now, it is a mutation in the gene CFTR. Now, what happens in sweat is, remember this chloride channel, it actually absorbs chloride in the sweat. It normally absorbs chloride. So, if this channel is not working, sweat chloride is high. But remember, in the gut and the pancreas, this channel actually secretes chloride. This channel actually secretes chloride. So remember, the chloride is low in the pancreatic secretions, but paradoxically it is high in the sweat. Okay, very good. So all of you should know the diagnostic criteria of cystic fibrosis. A typical patient, if he has got sweat chloride more than 60 milliequivalents per liter on 2 occasions, this is called cystic fibrosis. Normally the sweat chloride is less than 40, but if it's more than 60, that's called cystic fibrosis. Excellent. Let's take you to the next question, the next MIQ, the next most important question. And students, मैं लिख के दे देता हूँ, biliary atresia पे question आएगा. Very important. So remember, here is a 6-week-old infant who comes to you with persistent jaundice, dark urine and pale stools. So here is a child, basically a neonate, who comes to you with cholestasis, neonatal cholestasis. Now he has direct jaundice, which we could even see on the history. They were apigmented stools, direct jaundice, GGT is high. Now GGT also reflects surgical causes. If there are surgical causes, GGT is very high. Now the question is, which pathological finding suggests biliary atresia? Now remember, in biliary atresia, we do liver biopsy for 2 reasons. Number 1, to diagnose, and in biliary atresia, we see bile duct proliferation, bile plugs in the biliary atresia in the liver, number 1. Number 2, liver biopsy also helps to exclude other causes. Liver biopsy also helps to exclude other causes of cholestasis. Remember, extrahepatic biliary atresia is now the most common cause of cholestasis in neonates, and we have to do early Kasai surgery within the first 60 to 90 days to prevent liver failure. So we need to diagnose this early because we want to prevent liver failure. Okay, so we want to prevent liver failure, so we want to diagnose this early. Remember this. liver biopsy is important. Now let's take you to another very important question. Remember, your NEET PG examiners love to ask you questions on neonatal screening. That in newborns we can do some tests to diagnose disorders early, so that we can start some dietary manipulations, we can start some hormonal replacement. So newborn screening is a very important topic. So in babies we usually do a heel prick. We take 2 drops of blood on a filter paper by a heel prick on day 3 to day 5 of life. Now here is a child whose TSH is 100 on a routine heel prick. He has no other symptoms. So remember, the cutoff of TSH is usually 20 in the first 2 weeks of life. So if TSH is high, this could be congenital hypothyroidism. Now remember, congenital hypothyroidism is the most common preventable mental retardation all over the world. Remember, congenital hypothyroidism is the most common preventable mental retardation. It's very common. 1 in 2000 live births. 1 in 2000. Now the first test, there is a controversy in the chat box, but remember, the first test has to be a nuclear scan. So the first test we do is a nuclear scan. Okay, because almost 85% of the congenital hypothyroidism is dysgenesis of the thyroid gland. 85% is dysgenesis of the thyroid gland. So we do a nuclear scan first, then we do a ultrasound neck. Okay, so first nuclear scan, then we do a ultrasound. Okay, but remember, if TSH is more than 80, ideally we need to start thyroxine early. Okay, so if TSH is more than 80, guys, don't wait for the scan. According to the Indian Society of Pediatric Endocrine, if TSH is more than 80, don't wait for the scan. Start thyroxine. You should not wait for the scan. Let's go further, guys. And the next question is very important. Again, here is a child, a 7-month-old infant, who comes to you with sudden flexor spasms in clusters. Whenever he gets up in the morning, he gets these bilateral symmetrical flexor contractions like a salam. So he is having infantile spasms, which looks like a salam. Also, the triad is called the West syndrome. Now remember, EEG is very classic of infantile spasms. Now EEG shows all over the brain chaos. It's a multifocal spike and slow waves. Okay, hips arrhythmia. Remember, the drug of choice for infantile spasms is intramuscular ACTH. Drug of choice for infantile spasms is intramuscular ACTH. Intramuscular ACTH, followed by vigabatrin. It is followed by vigabatrin. So my question to you is, question 11. What is the drug of choice if I say infantile spasms in tuberous sclerosis patients? What is the drug of choice for infantile spasms in tuberous sclerosis patients? It is vigabatrin. So remember, only for tuberous sclerosis patients, the drug of choice is vigabatrin. Okay, so I said normally, in infantile spasms, the drug of choice is intramuscular ACTH followed by vigabatrin. But for tuberous sclerosis infants, vigabatrin is the drug of choice. Okay, guys, yaad rakhna hai sabko. This is very important. I can tell you that all of these are very important MIQs for your exam. Let's go further. And now let us talk about question number 12. It's a 11-year-old boy who got pain abdomen and palpable purpura. Urine analysis is normal. What is your diagnosis? Anyone? Question 12. What is your diagnosis? Pain abdomen with palpable purpura. Pain abdomen with palpable purpura. So this is the most common vasculitis in children called Henoch-Schonlein purpura. The most common vasculitis in children. Now we also call it as IgA vasculitis. IgA vasculitis. So the new name is IgA vasculitis. Remember, it is the most common vasculitis in children. It is the most common small vessel vasculitis in children. And it is also the most common leukocytoclastic vasculitis. What do I mean by leukocytoclastic? It means that WBCs are invading the vessel wall. Now here kidney is normal, urine is normal. But remember, kidney may be involved in 30 to 50% of patients. So nephritis may be seen in 30 to 50% of these patients. Now all of you should know that your examiners love to ask, when do we give steroids in HSP? So remember, the indication of steroids in HSP is severe pain abdomen, do rule out intussusception. Please remember, do rule out intussusception in these patients. I have a question for you guys, and parents commonly ask me this question. They ask me, sir, please give us steroids, we don't want kidney problem. So do you think early steroids prevents nephritis in HSP? Do you think early steroids prevents nephritis? And the answer is no. Early steroids does not prevent the nephritis. So it is evidence based. So there is a lot of evidence on this. So severe pain abdomen gives steroids. Yeah, of course, if there is a nephritic presentation, we give prednisolone. If there is a rapidly progressive glomerulonephritis, or we say crescents, we give IV steroids. If someone has rapidly progressive kidney failure, we give IV steroids. Then we also give steroids in pulmonary hemorrhage. If these patients rarely get pulmonary hemorrhage, we also give steroids. Orchitis. See, gonadal vessels are also small vessels. So suppose someone in HSP has got severe pain, testicular pain. So in severe testicular pain also, you can give a short course of 3-4 weeks of steroids. Let's go further. Now all of you should know that your examiners love to ask you one question on vaccine. So my next question to you, all of you, is which vaccine according to the national immunization schedule is given to a 10-year-old child? What do you think? Dr. Juneja, no, not for arthralgia. Steroids are not given just for joint pains, no. So yeah, so to a 10-year-old, usually we give TD, or you can also give TDAP. What do I mean by small d? It's a low dose diphtheria toxoid. What do I mean by small AP? Low dose acellular pertussis. Low dose acellular pertussis. So you can give TD or T small d small AP. Low dose diphtheria toxoid and low dose acellular pertussis. Okay, let's go further. Now again, guys, your examiners love to ask questions on resistant rickets. So all of you should know the algorithm for how to manage and evaluate a patient of resistant rickets. So let me first, before going to question number 14, let me first give you an algorithm. So if you have a patient of resistant rickets who is not responding to vitamin D, okay, So your first step is to get a serum phosphorus. Remember, normally serum phosphorus is 3.5 to 5.5 milligrams per deciliter. If serum phosphorus is high, that's called CKD MBD, chronic renal failure, or mineral bone disease in chronic kidney disease. Mineral bone disease in chronic kidney disease. Now, if it is low, now there can be three possibilities. First is renal tubular acidosis. Renal tubular acidosis. Rickets is usually seen in distal RTA, distal renal tubular acidosis, and Fanconi syndrome because of the loss of phosphorus. So in renal tubular acidosis, there would be acidosis, a normal anion gap metabolic acidosis, NAGMA, NAGMA. NAGMA is normal anion gap metabolic acidosis. Now the second topic differential can be vitamin D dependent rickets. It is a very severe kind of vitamin D deficiency, so severe body has tried his best, but the calcium has gone down. All of them have a history of seizures, tetany. All of them have a history of seizures, tetany. All of them have low phosphorus. Body has tried his best. So all of them have secondary hyperparathyroidism, but calcium is low. And let's talk about the most topic of the day here, the X-linked dominant hypophosphatemic rickets. In X-linked dominant hypophosphatemic rickets the problem is that now we know our body has a new phosphate uric hormone, a new hormone which liberates phosphorus, FGF23. It is a newly discovered hormone which secretes phosphorus. Okay, so the problem is phosphorus is lost, there is no relation to calcium. Phosphorus is low, there is no relation to calcium. So PTH is always normal here. PTH is always normal, phosphorus is low. Yes, mutation in the FEX gene, you are right, Dr. Jan. It's a mutation in the FEX, PHEX gene, FEX gene mutation. Okay, so let's go to question number 14 first. Let's all of you ask you, here is a child who did not respond to the conventional cholecalciferol therapy for rickets. His calcium is normal, PTH is low, his phosphorus is low, PTH is normal. Phosphorus is low, PTH is normal. What is your diagnosis? Question 14. Dr. Patel, what's your question? Can you please type again? So what is your diagnosis here? Phosphorus is low, calcium is normal, PTH is normal. So this is a classic X-linked dominant hypophosphatemic rickets. So this is a classic case of X-linked dominant hypophosphatemic rickets. Now all of you should know question number 15. See, in India, what we do in these patients is they are losing phosphorus, we give them phosphorus supplementation. We give them vitamin D, active 1-alpha vitamin D supplementation. So the treatment in India, has been giving phosphorus supplementation and giving 1-alpha hydroxylase or the active vitamin D. Now my question to you is, what is the new drug approved by the US FDA? What is the new drug approved by the US FDA for hypophosphatemic rickets? So for hypophosphatemic rickets, the new drug it's a subcutaneous drug called burosumab. Burosumab is a subcutaneous drug. It actually improves their phosphorus levels, improves their bone maturation, and of course it neutralizes the excess FGF23. It is a humanized monoclonal antibody. It's a monoclonal antibody against FGF23. So burosumab is recently approved by the US FDA. So in America, Europe, every hypophosphatemic rickets gets burosumab. But in India, it's a very costly medication. It costs something like 14 lakhs every month. So it's a very costly medication in India. Okay. Yes, Dr. Patel, you're right. Let's go further. Now, another favorite question of your examiners is a triad. A triad of microangiopathic hemolytic anemia, microangiopathic. So basically there is a small thrombus in the vessel. So it's a microangiopathic hemolytic anemia, thrombocytopenia, and acute kidney injury. So this triad of microangiopathic hemolytic anemia, thrombocytopenia, and acute kidney injury is called hemolytic uremic syndrome, HUS. Now this patient had a bloody diarrhea and now he's got HUS. So remember, in the developed world, all over the world, the most common cause is E. coli. Only in the developing countries you can say Shigella. Only in the developing countries you can say Shigella. But all over the world, the most common organism is E. coli. Someone, just had a burger today. Someone just had a roll today, which was contaminated with E. coli 0157H7. Okay. Now, how do we treat this? So in infections, if it's infection related, the treatment is supportive care. So if it's infection related, we just give fluids. So the most important is IV fluids. Rehydration is known to prevent kidney failure. So hydration and supportive care. However, if you are suspecting a genetic complement defect, then the drug of choice is IV eculizumab, which is a humanized monoclonal antibody against C5. So if you are suspecting a genetic complement defect, then only you think of eculizumab. Okay. So remember, in typical hemolytic uremic syndrome, Dr. Edge in the chat box, usually we give supportive care only. Only if you're suspecting some genetic disorder of complement cascade, then only you go for, remember, you go for eculizumab. Okay. Now my question to you guys is, so in this patient who has got question 17 diarrhea, and now he has got HUS, diarrhea, dysentery related HUS, what is your drug of choice? Question 17, guys. This is actually a diarrhea related, I would say most probably a Shiga associated HUS. Antibiotics in fact is controversial in these cases. Sometimes antibiotics can even aggravate that. So remember, in Shiga HUS the treatment is supportive care and hydration. Dr. Muhammad in the chat box, hydration is known, there are multiple studies on this. Hydration in these patients early prevents kidney failure, kidney damage, improves the long-term outcome. Okay, so supportive care is the treatment. Antibiotics somehow may even aggravate in these patients. Eculizumab only if you're suspecting atypical features of a genetic defect, we will go for eculizumab. Okay, so remember, for infection associated HUS, supportive care all over the world. Let's go further. Now my question to you is a very common question somehow asked in all of your exams: which hormone is not needed for growth in utero? Which hormone is not needed for growth in utero? You will mark eculizumab if you are suspecting C3 is low, neurological symptoms, family history. So remember, growth hormone is not needed for growth in utero. Okay, growth hormone is not needed for growth in utero. So patients who have growth hormone deficiency, remember, they are born normally and they just have a lag only around 1 to 2 years of life. Only at around 1 to 2 years of life they get a lag. So remember, in utero growth depends on insulin. and insulin like growth factors. That is why all of you know that in infants of diabetics, they are macrosomic because of insulin and insulin like growth factors. Thyroxine is important for the brain maturation in utero. So thyroid hormones are very important for brain maturation in utero. And today we talked about congenital hypothyroidism also. So let's talk about short stature. We talked about growth hormone deficiency. Now remember, somehow in every exam of yours, you'll have a question on disproportionate short stature. All of you should know that our upper segment to lower segment ratio in a newborn is 1.7:1. In a newborn is 1.7:1. And at almost 10 years of life, so OP Ghai textbook says 10 years, it becomes 1:1. In adults, it's 0.9:1. So my question to you is, in which of the following this ratio is reduced? In which of the following the upper segment is short? And now there's a controversy. Dr. Neha, Shigella, somehow dysentery is rare in India. So in India, in Bangladesh, Shigella dysentery is common, but not in India. There was a very big study and they found that even in India, Shigella is rare. Okay, Dr. Rizwan and Dr. Neha. So remember, in spondyloepiphyseal dysplasia and TB spine because of collapse of a vertebra and mucopolysaccharidosis type 4, which is called the Morquis disease, the upper segment lower segment ratio is reduced for that age. Okay, in the first three examples here, in achondroplasia, hypothyroidism and rickets, since the lower segment is small, in rickets, you know, there is bowing of the limbs. Achondroplasia, autosomal dominant, short limb dwarf. Achondroplasia, autosomal dominant, short limb dwarf. Here upper segment lower segment ratio is increased. Remember, in growth hormone deficiency, the ratios are normal. It's an example of proportionate short stature. So in growth hormone deficiency, he is a proportionate short stature. Okay, Dr. Tanmay? In a 15-year-old, his ratio is reduced. So we'll give him we'll think about spondyloepiphyseal dysplasia. Okay. In achondroplasia, ratio is increased, beta, increased. Okay, Dr. Vidya, increased for that age. Okay. So now we have a similar question. I told you, you know, at 10 years, the ratio is 1:1. Now here is a 14-year-old girl who is short and she is disproportionately short. Her upper segment lower segment ratio is increased. Now I want all of you to tell me, short stature, disproportionate. So the upper segment lower segment ratios are not as per the age. Okay, so what will you think of? Moreover guys, this child has frontal bossing and trident shaped hands. Frontal bossing and trident shaped hands. Yes, now you are right, guys. This is achondroplasia. So in achondroplasia, it is an autosomal dominant disease, short limb dwarf. You can also have trident shaped hands, hydrocephalus in achondroplasia. In spondyloepiphyseal, remember the upper segment lower segment ratio is reduced. In growth hormone, it is a proportionate short stature. Even in Turner's, it's a proportionate short stature. A genetic short stature in girls is Turner's. In hypothyroidism, the upper segment lower segment ratio is increased. Okay, we just told you this. Remember, exam mein question aayega on disproportionate short stature. You have to remember this. Okay, and I just gave you all the examples of disproportionate short stature. Okay, yaad rahega sabko? Can you write promise on the chat box that you will remember whatever I told you today? These are the most important topics and the most important questions for your NEET PG and also for your FMG. My name is Sidharth Sethi. If you have doubts, feel free to email me. I would say email me. I am very prompt in responding to emails. You can tag me on social media platforms. And on behalf of the DAMS family, I wish you all the best for your NEET PG exam. And I'll see you on the other side when you will be a PG and I'll be a consultant, scolding you on the other side. Thank you. And remember these PYQs and the MIQs. Thank you.